To continue discussing red blood cell formation, I think it is worthy to discuss the significance of a reticulocyte count in a healthy patient. First, let's recognize that when the number of red blood cells and hematocrit decreases, the percentage of reticulocytes may appear falsely increased compared to the overall number of red blood cells. In order to get a more accurate assessment of bone marrow function, the calculated reticulocyte percentage is often corrected with a calculation called a corrected reticulocyte count, or a reticulocyte index. This calculation compares the patient's hematocrit with a normal hematocrit value. The reticulocyte count is a reflection of recent bone marrow activity. If your bone marrow is responding appropriately to the demand for increased numbers of red blood cells, then the bone marrow will allow for the early release of more immature red blood cells, increasing the number of reticulocytes in the blood. If you bleed, hemorrhage, then the number of reticulocytes will rise a few days later in an attempt to compensate for the red blood cell loss. If you have chronic blood loss, then the number of reticulocytes will stay at an increased level as the marrow tries to keep up with the demand for new red blood cells. If your marrow is unable to keep up or is not functioning normally, then the number of reticulocytes may be normal or only slightly elevated despite demand, but will eventually decrease due to lack of adequate production. If the number of reticulocytes is not elevated when you are anemic, then it is likely that there is some degree of bone marrow dysfunction or failure, and/or a deficiency of erythropoietin. Patients who move to higher altitudes may have increased reticulocyte counts as their body adapts to the lower oxygen content of their new location. Smokers may also demonstrate an increased number of red blood cells and reticulocytes. Reticulocyte counts may be increased during pregnancy. Newborns have a higher percentage of reticulocytes, but the number drops to near adult levels within a few weeks. Reticulocytes, just to say it again, is a young erythrocyte. The cytoplasm still contains a large number of ribosomes and endoplasmic reticulum, and RNA, of course, which is being used during translation to make the hemoglobin chains. Ribosomes have the ability to react with certain dyes, such as brilliant cresol blue or a stain known as new methylene blue, and it forms a precipitate which stains, obviously, blue. This reaction occurs only on staining of cells that are still alive and not fixed. Therefore, this is called supravital staining. I'm showing a picture on this slide of some reticulocytes. Reticulocyte count is an indicator of bone marrow activity and is used to diagnose anemia. The number of reticulocytes in peripheral blood can be increased or decreased, like I said, for various reasons. Reticulocyte count and percentages can change. A decrease in numbers can be an indication of anemia. It could be an indication of bone marrow failure, aplastic anemia, or hypoproliferative disorders. An increased number can also be an indication of anemia, as the body is trying to compensate by producing more red blood cells by releasing more reticulocytes into the bloodstream. Obviously, just taking the count of reticulocytes is simply a marker to detect a change. It is just an indicator, and more tests would have to be done to actually find out what's going on in the patient. I want to tell you about the erythrocyte sedimentation test. Basically, this is a test where you get a rack, and I have the rack shown here, and the rack holds some capillary tubes. They sit vertical in the rack. And you take a whole blood sample from your patient and you add some saline solution to dilute it, and then you make sure it's mixed. You then put it in the rack, this capillary tube, and you wait for 1 hour. And what happens is the red blood cells are going to fall due to their density. They're going to settle down to the bottom of the tube. You are measuring the distance that they fall in that 1 hour. If you look at that bottom right picture, you are seeing that the height of the red blood cell column has dropped from the top. What are normal ES rates or SED rates? In males, their red blood cells should drop about 20 millimeters in 1 hour, roughly. In females, it will be a little bit faster. They're going to drop about 22 to 25 millimeters per 1 hour. That's because they have fewer red blood cells and there will be less of a rouleau formation, assuming a normal, healthy female with no autoimmune or inflammatory disorders. Okay, so what is a rouleau formation? The top picture shown here with the red blood cells stacked like coins is showing you a rouleau formation. Now here's my analogy. Let's say you are making Jell-O. You've heated up the Jell-O and it started to congeal. If you were to put pennies on top of the Jell-O, they would fall down to the bottom of the pan. But let's say you have a stack of pennies that you put on top of this Jell-O, compared to just a single penny. Which would fall to the bottom of the pan faster? I hope you agree that the stack of pennies would actually fall faster to the bottom of the pan than a single individual penny. That's a rouleau formation. Red blood cells that can stack together. This is not clotting. Clotting deals with platelets. That is something completely different. What does the rouleau effect tell us? There is something changed about the red blood cells that allow them to stack together, and when they form this rouleau formation, they will actually have faster SED rates. In healthy individual red blood cells, they don't really settle very much in an hour. But in some disease conditions, increased production of fibrinogen and immunoglobulins and other inflammatory proteins can cause red blood cells to clump together, to stack up, to form this dark red column known as the rouleau formation. Again, everyone has a SED rate, but not everyone has a condition where the red blood cells would have a rouleau formation. That formation may or may not occur. The SED rate is neither very specific nor diagnostic, but it can be used to follow the progression of certain diseases, including sickle cell anemia, some cancers, inflammatory diseases such as rheumatoid arthritis, and others. When the disease improves, the SED rate decreases, fewer millimeters per hour. SED rates can be elevated in iron deficiency anemia, meaning faster, more millimeters per hour. And menstruating females sometimes develop anemia and show an increase in SED rates. The SED rate can also be used to evaluate a patient with chest pains because the SED rate is elevated in established myocardial infarction due to the release of cellular signals from the dying cells, that is, C-reactive protein. But the SED rate is normal in angina pectoris, chest pain without a myocardial infarction. Similarly, it can be used in screening a female patient with severe abdominal pains because the SED rate is not going to be elevated within the first 24 hours of acute appendicitis, but it is elevated in the early stage of acute pelvic inflammatory disease or a ruptured ectopic pregnancy. Even though SED rate doesn't really tell us much, the SED rate is still used clinically. Let's practice. If a person is diabetic, would you expect a slow or faster SED rate? You would actually get a slower sedimentation rate, fewer millimeters per hour, because the plasma is more viscous due to the increased glucose. It's thicker, and so the SED rate would be slower in the diabetic. What about polycythemia? The SED rate, again, will be slower, so they are not going to have as many millimeters per unit of time where the red blood cells are dropping because there are too many getting in the way of each other. Let's continue on talking about iron. Iron is obviously an ingredient for proper red blood cell formation. We get iron from our diet. Now, you might eat a lot of iron. However, you only absorb just a little bit of iron. I'll talk more about this when in our next slide on hemochromatosis. So our normal absorption of iron from our diet is only about 10% of what we eat. The iron, when it gets into the plasma after we absorb it, will bind to a plasma protein. This plasma protein, without iron bound to it, is called apotransferrin. Once iron binds to it, it's called transferrin. Then the transferrin will deliver this iron to the cells that can store iron intracellularly, like hepatocytes, for example. Hemocytoblasts, our bone marrow cells. Once the iron is given to the cells, there is a cytoplasmic protein called apoferritin. Once it binds to the iron, it's called ferritin. Again, ferritin is a cytoplasmic protein that has iron bound to it. This is the preferred way to store iron in our cells. However, iron levels can go up. Maybe we are absorbing too much iron, and again, I'll discuss this in a little bit. If there is too much iron stored within cells, if we overwhelm the apoferritin, then iron can form crystals, and this is called hemosiderin. It is extremely insoluble. That's why the iron crystals precipitate out of the cytoplasmic fluid. It is also toxic to cells. This most certainly is iron overload. Iron can be in different oxidative forms. It can be in a +2 state or a +3. The +2 state is more reduced than the +3 state, which is more oxidized. The +2 state is ferrous iron. The ferrous iron is the form that can bind, interact, carry oxygen. Ferric iron, iron that is oxidized or in the +3 state, does not bind with oxygen. This type of iron would be useless to us. We would have a reduced oxygen carrying capacity if more of our iron in our hemoglobin was in this +3 state. Hemoglobin with iron in the ferric form is called methemoglobin. I will be discussing a type of anemia where an individual has a higher amount of this methemoglobin. Understand, all of us have some levels of methemoglobin. Oxygen is an atom that can remove electrons, and oxygen can remove an electron from ferrous iron and turn it into ferric. So the liability, if you will, of carrying oxygen on iron within hemoglobin means that the iron can sustain oxidative damage. Thankfully, within our red blood cells, we have the ability to repair this oxidative damage and return the iron to the ferrous state. Some people are not capable of repairing this oxidative damage and therefore have a higher level of methemoglobin. I will discuss this towards the end of this lecture. To move on and keep talking about what we need for a healthy red blood cell, I want to talk about hemochromatosis. This is a recessive genetic mutation. As I said earlier, we normally absorb about 10% of our ingested iron. In hemochromatosis, with this recessive mutation in a gene called the HFE gene, a person can actually absorb about 30% of their ingested iron. This can certainly lead to hemosiderin, where the iron is now stored in the in the cytoplasm and precipitates out of solution. With the increased hemosiderin, we're going to see that organs that are capable of storing iron are going to be at a huge risk for large cellular damage. First of all, the liver, heart, and pancreas would be some of these organs, but they are not the only ones. These organs will start to fail. We'll see elevated liver enzymes, cirrhosis of the liver, which means the hepatocytes are being replaced by scar tissue. Hepatomegaly, which means we're going to see an enlarged liver in this patient because the cells are storing copious amounts of this hemosiderin. The heart may start to show signs of arrhythmias. In the pancreas, the iron is going to kill off beta cells in the islets of Langerhans, so the person may present with diabetes mellitus. This person is also going to present with a bronze kind of skin. And sometimes we refer to this disease as bronzed diabetes, when it's the diabetes caused by the hemochromatosis. In general, it's going to cause organ failure. It also leads to pain in the joints and abdomen and fatigue. Maybe you're wondering how common hereditary hemochromatosis is. It's actually a relatively common inherited disorder. About 3 to 5 people per 1,000 of Northwestern European ancestry are homozygous. As I said before, this is a problem with increased absorption of iron from the diet. It is an autosomal recessive disease, and it becomes clinically significant only in the homozygous individual. If left untreated, hereditary hemochromatosis, or HH, can be fatal. The excess iron is stored in the liver where it reaches toxic concentrations. There is also pituitary and gonadal failure and arthritis. The disease hardly ever becomes apparent before the individual enters their 3rd decade of life. Women are relatively protected as long as they are premenopausal because their monthly menstrual flow keeps total body iron stores relatively normal. Treatment is reminiscent of the medieval approach to the disease, which is to remove or phlebotomize 1 or even several units of blood on a regular basis until the iron overload is corrected, as evidenced by the normal plasma ferritin levels. Afterwards, most patients require phlebotomy, only once every few months, to maintain their low iron stores. Let me correct myself a little bit. The iron overload will be shown as being corrected when we see normal plasma transferrin levels and normal cytoplasmic ferritin levels. The role of the mutation in the HFE gene is not yet clear. Attention has been focused on hepcidin, a recently identified hepatic protein that appears to play a critical role in the regulation of body iron stores and duodenal iron absorption. Normally, increased body iron stores reduces iron absorption. Hemochromatosis represents an inappropriately high rate of iron absorption relative to body iron stores. In other words, you're supposed to be in this negative feedback state. If your body iron stores are high, then you should have decreased GI absorption of iron. You don't need more. You have enough in you already. In hemochromatosis, we are seeing that the iron stores are high in the body, but yet there is still a high absorption rate. The hepcidin is supposed to downregulate iron absorption, and hemochromatosis may represent a defect in the regulation of hepcidin. Then again, we are not really sure of the relationship between the HFE gene and its mutations and hepcidin itself. Let's move on discussing what else we need in order to make a healthy red blood cell. Specifically, I'm focusing on the ingredients for hemoglobin. We need iron, we also need something called a pyrrole ring. And this pyrrole ring is made early on in the development of red blood cells, as early as the proerythroblast. This pyrrole ring is synthesized within the mitochondria of a proerythroblast. Mitochondria are still present in the proerythroblast stage. How do we make this pyrrole ring? In the center box, I am showing you the ingredients for pyrrole. We need a succinyl-CoA, we need 2 of them, and glycine. Please don't memorize this. Those are assembled into a pyrrole group, shown here. Next, 4 of those pyrrole groups are then linked together to form a ring called protoporphyrin 9. After that, protoporphyrin 9 plus iron in a +2 state, or ferrous iron, are assembled together. Now you have a heme. So if you look in the picture to the right, the picture within the green circle, you can see the iron in the center of this protoporphyrin ring. The protoporphyrin 9, or protoporphyrin ring as I just called it, is called that when you don't have the iron in the center. When you add the iron to the center, then the ring plus iron gives you a heme group. Then that heme group is inserted into a polypeptide globulin chain. Remember, we're making hemoglobin, so I shouldn't say globulin, but globin chains. And then you have your hemoglobin chain, either an alpha or a beta. When we assemble 2 alpha chains and 2 beta chains, we then get adult hemoglobin, or hemoglobin A. So let me say this again. We need 4 pyrrole groups assembled into a ring. This is then called the protoporphyrin ring. When we add iron to the center of that ring, we now call it heme. When we take this heme group and add it to a globin polypeptide chain, either an alpha or a beta, we then have a hemoglobin chain. When we have 2 alpha chains and 2 beta globin chains assembled together, we now have adult hemoglobin, or hemoglobin A. On the next slide, I will tell you about the different types of hemoglobin we make at different stages of our life. So hemoglobin itself is a large molecule. It actually has 4 polypeptides that are linked together through interactions between the amino acids. And in each center of each polypeptide, in the center of each polypeptide, we have a heme group. And remember from the previous slide, heme means that you have the protoporphyrin ring plus iron. So we have heme, iron, and iron is the provides this pigment, and that's why our blood looks red. And it is the iron that's going to interact with oxygen in a reversible way, meaning oxygen is going to bind to hemoglobin when it crosses the capillary beds in the lungs, and then the oxygen is going to be released when the red blood cell goes through a capillary in a tissue bed. So how many molecules of oxygen can each hemoglobin protein bind, meaning the entire molecule? And that is 4. 4 molecules of oxygen can bind to 1 hemoglobin molecule. 1 molecule of oxygen interacts with each heme group. Let me tell you a little bit more about those globin chains. Why use globin chains or have them in the first place if it's iron within the heme group that interacts with oxygen? Why have them? Well, it turns out the globin chains are the molecules that will determine the affinity for oxygen. I'll explain what affinity is in just a moment. The globin chains are gene expression products. So they are proteins that come from genes. They are coded, these genes are found on chromosomes 11 and 16. So, for example, the beta globin genes are found on chromosome 11, and the alpha globin genes are found on chromosome 16. These genes are expressed throughout our life in at different times, and this is important because we're going to have different affinities for oxygen. Let me explain. Embryonic hemoglobin has alpha-2 genes, and again, the alpha-2 subunits are expressed on chromosome 16, or are found on chromosome 16. But on a different chromosome, we have epsilon genes. And when we make embryonic hemoglobin, which was during the first 3 months of gestation, it is alpha-2, epsilon-2. And during embryogenesis, when you were an embryo, you did not have your blood vessels developed quite yet. You were relying on diffusion of oxygen through your mother's uterine tissue and diffusing into your embryonic tissue. So in order for the oxygen to be pulled away from your mother's uterine tissue into you, the developing embryo, you had to have a high affinity hemoglobin. Fetal hemoglobin has alpha-2, gamma-2 subunits, and this happens after 3 months of gestation and will be replaced within 6 months of birth. So, and the timing and tempo of this is variable from person to person, from baby to baby. But overall, the fetal hemoglobin will be completely replaced by adult hemoglobin within 6 months of birth. Adult hemoglobin is the alpha-2, beta-2 groups or globin chains. And again, the alpha-2 and beta-2 globin chains, the genes are found on chromosomes 16 and 11, respectively. The highest affinity is the embryonic hemoglobin, the middle of the road is fetal, and then the hemoglobin with the least amount of affinity is the adult. When you were a fetus, you did have blood vessels that were developed, and the blood vessels from your extraembryonic membranes, meaning the blood vessels that were coming out of your umbilical cord or going into your umbilical cord, grew into your mother's uterine lining, into close proximity with her blood vessels. So once you had those blood vessels established, you didn't need embryonic hemoglobin anymore. You could use a less stringent hemoglobin, a hemoglobin that had less affinity for oxygen, because again, your blood vessels were in close proximity. Maybe affinity is a new term for you. Maybe I should actually explain what that is. It is a term we use in biochemistry to refer to the tightness that two molecules want to interact with each other, how tightly they want to bind or not. The higher the affinity, we think of more greediness, less likely to let go. The lower affinity, we think of less greedy, more likely to let go. So a high affinity hemoglobin is going to want to bind very tightly to oxygen. This is great when you're a developing embryo and relying on diffusion of oxygen from your mother's uterine lining into your developing tissue. You would need a less affinity hemoglobin, a lower affinity hemoglobin, if you will, when you were a fetus, when you had blood vessels that had developed in close proximity to your mother's uterine arteries. Then, as you were born and breathing on your own, and you were getting oxygen into your own lung tissues and having oxygen diffuse across your lung pulmonary capillary beds, you did not have to have a high affinity hemoglobin, and you started converting to adult hemoglobin. So I have 3 different pictures of couples here, and I just want you to think about which couple seems to have the highest affinity, and which couple do you think has the lowest affinity. And just think of these pictures as examples of the embryonic, fetal, and adult hemoglobin. Now, here's something pretty cool. This affinity can change. This affinity can change within a globin polypeptide interacting with its heme group, and it can also change in between the globin chains. This is, when we see this kind of interaction, it's called allosterism. Allosteric interactions. Allosteric interactions basically mean changes in one part of the molecule are communicated to other parts of the same molecule by changes in the molecule shape. Changes in shape means conformational changes. So every time an oxygen loads onto a heme group or comes off, this will change the shape of the other globin chains and also cause those heme groups in those globin chains to release oxygen or bind to it. Remember, hemoglobin is a tetramer. It has 4 globin chain subunits. Each one has its own heme group. On the next slide, I'm going to show you oxygen hemoglobin dissociation curves, or we say oxyhemoglobin dissociation curves. And when I show you this graph has a sigmoid shape, an S shape. And this S-shaped curve tells us that there are allosteric interactions, allosterism, occurring between the 4 subunits in any one hemoglobin molecule. The analysis of this S-shaped curve, the slope of it, tells us that hemoglobin's affinity for each of the oxygen, whether loading or unloading, is not the same. To say it in words before I show you in the graph, when unloading oxygen from hemoglobin, you will see it is hardest to pull off the first oxygen. That means the hemoglobin has the highest affinity when all 4 oxygen are loaded. As you take off one oxygen molecule from one heme group, the rest become progressively easier until we get down to the 4th last oxygen. Plucking it off can be a little bit harder. Not harder than the first, but a little bit harder than the 3rd. Again, I'll show you this on the next slide.